I'm Paul Drumheller, and I'm a practicing physical therapist and owner of 3-Dimensional Physical Therapy way up in Tacoma, Washington. And they had me, Performance Health had me come out today to talk about basic foot mechanics, and some potential causes of pain in the foot. And then we're also going to get in some fun stuff, which is exercise, and that's what we like to do, and that's where we're going to use the products. So the foot itself, the pain in the foot can be caused by a couple different things. Intrinsic factors, which are inside your foot. So you got bones, muscles, ligaments, tendons, all that stuff. And you also have extrinsic factors, which are outside the foot. So you're looking at the lower leg, the knee, the hip. You got to look at femur, varices, and the valguses, and the retroversions, and torsions, and all those things that can come into play. Leg length difference. All that can cause some foot pain or cause the foot to function differently. So the function of the foot, it basically has two parts. You have a rear foot, which is your tibia, fibula, talus, and calcaneus. And you also have the mid-tarsal joint that separates to go to the forefoot. So the mid-tarsal joints, you guys, a lot of students, what's the mid-tarsal joint? So you got calcaneocuboid and talonavicular joint here. So between everything there is forefoot. We're going to keep it that simple. The function of the foot is to basically get your foot flat. Get your foot flat on the ground. When the rear foot, when it hits the ground, it's going to pronate as much as it can to get the big toe to the ground. Once it gets the big toe to the ground, the foot's done its job. It's fine with that. The pronation and supination can occur in the rear foot, but it can also occur in the mid-tarsal joint. Okay? So if you look at the foot's complex, it's like an ugly hand, we call it, for hand therapists. There is no certified foot therapist because we can't agree with what the best way to treat it is. But if you look at foot orthopedic injuries in general, 90+% are going to come from a stability or mobility problem. Right? If you look at the mobility stability model, your foot should be rigid or should be stable. Your ankle should be mobile. Your knee should be stable. Your hip should be mobile and up the chain. So if one of those factors doesn't happen, your body's still going to adapt or compensate to allow you to move forward. So we have a simple goal in life. It's to move forward. If you look around here at all these people walking, you're going to see all kind of different ways to move forward, and you still get there. So if it's a mobility problem, how do we do that? What do we work with? Give me something. Give me one thing to treat a mobility problem. You're gonna active mobilizations, passive mobilizations, taping, instruments, soft tissue work, modalities, anything out there. I'm not gonna tell you how to do that. It's a whole nother class, and again, there's a lot of different variabilities on that and what we can agree with. But the difficult part comes when it's a stability problem, because now you can use passive supports such as tape, orthotics, shoe wear, bracing, anything like that. But as PTs, we want to work with what we have available. Muscles, right? Muscles, and more importantly, the timing of the muscles. I don't really care about the strength in the foot. The foot have basically intrinsic muscles. They are mainly to stabilize. You're not going to do 1,000 foot toe curls and come up with a bicep on the bottom of your foot. It's not going to happen. They're stabilizing muscle. So what we're going to work with is going to do some exercises to use the products that we have here. Again, over 20 years in the clinic, I've got, and 20 years of these, I have several devices that I've used in the clinic that I like. But we teach the class when the feet hit the ground, everything changes. A little shameless plug right there. But we use a lot of this stuff in our class. And so we're going to go through how to use this, and hopefully you guys have seen a lot of it. And if not, you guys can try it out. You guys can try it afterwards. So as for the sake of exercise, though, I have a real pet peeve. Again, 20 years of doing exercise stuff, is I don't like to do exercise just for the sake of doing an exercise. Every exercise you give someone should be for a reason. If someone asks you, why are you doing it? You better have an answer. And it may be, I'm doing this exercise because I want to think for a couple minutes of what I really should be doing, and this isn't going to hurt them. It still has a purpose. Okay? So just think about exercise-wise and for that. So we're going to start with some basic, let's go on the table. We're going to start with some basic exercise stuff. Is your foot inversion, eversions, all that stuff with your foot. Normally you can do it with a hand. You send patients home with TheraBand or any kind of band. I like this now because I don't have to worry about tying in a knot. And is it too loose? Is it too tight? All that stuff. So just basic exercises going from here and just doing a basic dorsiflexion. Okay? Simple as that. If the foot's going to slip off or you're afraid it's going to slip off for other ones, you can loop it in with itself and put it on, and now it's just kind of its own, it's going to self-tighten. So from here, you're going inversion, eversion. And same, you can hold it there. They can hold it themselves, or they can put it in a door. There's all kind of ways to hold it. Now, these are good exercises. And think about inversion, eversion. You're working the subtalar joint, so it's a triplanar motion. So you're not just gonna go straight side to side. It's not a talar tilt motion. It's down and in, up and out. It's this motion here. And same thing with plantar flexion or inversion, it's the same way. So inversion here, so from here you're coming down and in, up and out. So that motion there, not just straight side to side. Good early starting exercises, but we walk and stand and use our feet while we're on our feet. So let's go to that motion, let's go to those. So first one, we're talking about just resisted pronation, supination. It can be an assist or a resist for supination. Here you go. Yeah, just raise up above the legs from now. Yep. So from here, all she's doing is pronating, supinating. And so if someone has a mobility problem, they can't pronate, the band's going to help them pronate. If you want to slow it down and control eccentric pronation, you can do that with this too. Now, let's take it above the scope here. Yep. So now, we cannot forget about the hip, right? Because the hip can control, the butt can control what the foot does. So I can't tell you how many times I've had a person come in for a foot injury and they come back the next time and go, my butt is killing me. I can't get off the toilet. Why? What's wrong with that? So how I look at that, or how I explain why that is your feet. Let's go about, with all you guys, let's go about 8-10 inches apart with your feet. So from there, what I want you to do is squeeze your butt together as hard as you can. Okay, go ahead and relax. Now, pay attention to what happens with your feet. Squeeze your butt together again, and then relax. Now, when you squeezed, your feet should have gone to the outside. If that didn't happen, we got some mushy tushy syndrome. That's a whole other thing besides the foot. A whole other story. So, how we want to get glute involved. And we can do basic side raises and everything. But again, I'd like to have them on their feet so the proprioceptive factors, they have to balance. So go into a single leg stance here, and you go into a clamshell. Everybody does clamshells on the side. From here, doing a clamshell. What I'm looking for is this knee controls and doesn't get pulled in. Think about the whole terrible triad. If her knee goes into valgus, her foot's going to pronate, and we're trying to control that. And again, I'm throwing her in because she hasn't done a lot of these before. You'll see, it's hard. It's a lot harder. Let's go ahead and take this off. So again, the majority of life's foot problems is a pronation problem, for the most part. So what we're going to do is control pronation eccentrically. So you're going to hold this on your hip there. So I'm going to be the door. Pretty good at that. Standing here stable, and she's just going to hold on her hip. So balance on your left foot. So, yep, and then come in, go out. Okay, let's start there. Now go that way, and then come in. So as she comes in, she's got to control pronation. Watch what her foot does. She's got to control pronation here without falling over. And just go right to that. Yep, perfect. So go out again, come back in, stop. Again, first time, it's hard. It's very hard. And this is an easy band. So it gets a lot harder than this, but we'll get there. And then you can put them on different surfaces or whatever else. Again, for resisted pronation, look at the posterior tibialis stuff on the inside of the ankle pain, pronation control. We do heel raises. A lot of us do heel raises. But if you look at the studies with heel raises, even eccentric heel raises, when you come down to the bottom, you tend to pronate. People tend to pronate that way. So we're going to use this. We're going to pull them into pronation. She's got to fight against me. I'm going to go left side. It's a strong one. Yep. So the band goes here. Around her foot. And the CLX band does a really good job with staying on top of each other without sliding, and it's not too big that it's going to tear. And so from here, as she comes up to a heel raise, she's got to fight pronation. I'm pulling her into pronation here. She's got to fight that as she comes down. So she's got to work posterior tib extended period of time, trying to get to come down. And that's a lot harder. Now, do a regular heel raise now. So that's easier than the other way. So it's a lot easier, and you can ask them, it's a lot easier to do it that way. So again, you're trying to pull them into their area of dysfunction and make them work out of it. Whoa. Now, let's go to some other fun toys. So rocker boards. You've all seen the balance boards, a piece of plywood and a 2x4, right? Or a 2x2 underneath it. Those are good for controlling at your foot and ankle. What this does is it seems daunting by looking at it, how high it's off the ground and how big it's a U shape. It's actually fairly stable, but now have her go into pronation and supination, she's got to work a lot more hip and control, proximal control. So if someone has an issue, if they can't pronate more, then they can just move their foot a little bit right or left of the midline of the board. So it's from there. So now, let's go pronation. So the other way, ankle dorsiflexion is also a huge problem in our society, lack of ankle dorsiflexion. So just going dorsiflexion control, just go back and forth easy, yep. But when you're looking at athletic population or someone that's got a back pedal to come forward, that quick plant, when you have Achilles injuries or runners, they need that quick acceleration drill. So let's go a little quicker. You can even hold on the board. So it's quick back, quick back. First time doing it. There we go. Back, yeah. You see it. So it's a quick, so again, first time doing it, but it's from here, you're going quick out and back, quick out, back, quick out, back. So it's that quick acceleration to come out of it. And that's just a little variation to increase speed once they have good control of doing it in a controlled path. So back to wobble board. So now, ankle sprains, typically inversion ankle sprain. The main goal with an ankle sprain, we're trying to get back dorsiflexion and eversion, just the opposite way they sprained it. But we got to get back dorsiflexion to allow them to walk properly and allow them to jump properly. So with the board, instead of going complete circles, you can just go half of it, so you're staying eversion side of the rear foot. So you're not going into the area they sprain the ankle. Eventually, let's go full circles. We go full circles that way. Good. That's the easy ones. Now, just balance alone, balance in general, can be difficult. So she can balance on the ground. So again, we got to continue to challenge people, or they're going to get good at balancing on the ground, but they've got to do other things outside of the clinic. Different densities, different colors are different things. The blue is a little softer, so it's a little bit more difficult. The green is not. The green's easier. So we'll go the easy route to start with. So if you're just balancing on a single foot, yep. So vision, we all know vision's a big part of balance. So the single foot balance is look right and look left. You can look up and down. Now, besides vision, upper extremities can drive what happens to lower extremities, what happens with the feet and ankle. So single leg balance, and this is going to go overhead. Just alternate overhead. Okay, good. Now, let's switch up. Make it a little bit harder. That's too easy for her. So same thing, go above. You can see what the foot and ankle is working. Now, let's go out the side. So now, frontal plane stuff. Foot and ankle is triplanar motion, so you're working more frontal plane. Good. I like it. Yeah, that's right. It's always a heckler. Now, let's go. So triplanar. So we've done sagittal, we've done frontal, and now we got to do transverse. So go from here to here.
It's really bad.
Okay, it's difficult. You guys are going to try this. You're more than welcome. I want you to try this afterwards. Good. Good, good. And same thing with patients. The therapists that we work with, we all can do these. We all practice these. So when we demonstrate with the patients, I can't tell you how many times they go, oh, you guys make it look easy. Because we do it all the time. It should be easy. Now, the other one is split stance. So again, narrowing the stance, go split stance balance. So it's feet in line again. So standing in a balance board, different densities, and no matter what you do, if I ask any one of you guys to stand split stance tandem, your foot behind you is going to be your more dominant, the one you have confidence in balancing on a single foot. Every single time. Been teaching these classes for 15 years, every single time. Now, switch feet. So what do? We make them go the other way. And that's harder. So from that position, same thing. Look right, look left. And just watch the foot and ankle. Watch the timing of the muscles come into play. So again, these are all pre-programmed movements. She knows what she has to do. I'm saying do this, and her body's going, okay, I got to do this. So now, again, with ankle stuff, it's a reactionary drill. It only takes one time of going too far before she sprains an ankle. So from here, I'm going to push her around a little bit, and she's got to react to it. We can make it harder, make it faster. Good, okay, good. So she should be stable. You want that. You want the stability there. And when we do this a couple more times, she'll get better at it. Guarantee you. So with that, again, the products we use from Performance Health, they're definitely available all over here. We use them a lot in the clinic. And think about balance with the foot, start on the ground. Give them success, let them be successful before you throw them on the balance pad. If you're going true strength training, strength meaning high max reps, max load with low reps, 3 to 5 repetitions. Get them off of balance pads, get them off that. The studies have shown if they're on the ground, they're gonna have better support. You may think it's more challenging to work on a BOSU ball or something, a stability disc, whatever. For body weight, that's okay. But when you start loading, get them back on the ground, just for safe factors. So, with that.
Thank you.